Welcome back to the deep dive. Today, we are tackling a topic that is right at the absolute edge of what's possible in medicine.
It's technically astonishing, for sure,
Yeah.
and also just profoundly necessary when you get into the details.
We're taking a look at maternal fetal surgery. This is a field that, has completely transformed over the last 40 years. It's gone from these huge open abdominal procedures to incredibly precise, minimally invasive techniques.
Like fetoscopic surgery.
Exactly. But there's this one massive tragic hurdle that remains. What do you do when the fetal heart itself is just non-viable? When it's so malformed that there is zero chance of survival after birth?
And that is the absolute core of the proposal we're looking at today. It's a really revolutionary paper from Dr. Boris Petrikovsky and Dr. Levine Moten.
Right, and their work focuses on what seems like the ultimate challenge in this field, in utero heart transplantation. We'll probably just call it IUHT.
And for them, this isn't just some sci-fi thought experiment. They're making a serious argument that IUHT, actually replacing a non-viable fetal heart with a donor heart before the baby is born, is the logical next step.
So not just a concept, but something that is scientifically grounded and ethically feasible right now?
Yes. They see the barriers not as biological impossibilities, but as technical and logistical challenges that modern medicine is finally ready to solve.
Okay, so that's our mission for this deep dive. We're going to unpack their entire proposal, the science, the ethics, the tech, and see how they plan to move IUHT from this incredible idea into a real mainstream option.
With all the safety and governance that would require, of course.
Of course. So let's unpack this. The first big question has to be, why? What is the clinical necessity? Why does this have to happen in utero? Why can't we just wait until the baby's born?
Well, the necessity really comes from a place of, frankly, profound tragedy in congenital medicine. We're dealing with fetuses who are diagnosed with heart defects that are just completely incompatible with life outside the womb.
These aren't conditions that can be managed. These are fatal.
Absolutely fatal. Think of the most severe forms of hypoplastic left heart syndrome or incredibly complex arterial malformations. The heart structure simply cannot sustain circulation once placental support is gone.
And is this a very rare problem? Or are we talking about significant numbers?
It's more significant than you might think. We're talking about roughly 1 in 4,000 births in the United States.
Wow. Okay, what does that work out to?
That translates to nearly 1,000 fetuses every single year in the U.S. alone.
1,000 families a year facing this.
And globally, you're looking at estimates of over 40,000 cases. These are babies who typically die the moment the umbilical cord is cut, or within hours, their system goes into immediate irreversible collapse.
It's a certainty of death.
Yeah.
So, okay, that raises the obvious question. If the heart is the problem, why can't we just use neonatal heart transplantation? That's an established field.
It is, but it completely fails this specific, incredibly fragile group of infants. And there are a few big reasons for that.
The first one I'd guess is just finding a donor.
That's always the first hurdle in transplant, right? Donor scarcity. Finding a heart that's the right size for a newborn is incredibly difficult. The demand just massively outstrips the supply.
But Petrikovsky and Moten argue it's more than just a supply problem for these specific cases.
It's a physiology problem. The real killer here is what they call extreme hemodynamic fragility.
What does that mean in practice?
In utero, their circulation is supported by a whole different set of pressures and shunts. The moment the cord is cut, they have to switch to breathing air and using their lungs. For these infants, that switch is catastrophic. They immediately become hypoxic, their blood turns acidic. It's a rapid downward spiral.
So they don't have any physiological reserve. They can't handle the stress of being born, let alone waiting for a donor heart to show up.
Exactly. There's no time. The logistics of trying to stabilize them, find a donor, get the organ, and get them to an OR, it's basically impossible. Many would need immediate ECMO, which is a huge intervention.
That's the external heart-lung machine.
Right. But even ECMO needs a certain level of stable anatomy to work with. For these lethal defects, the window of stability is it's minutes, maybe hours, if you're lucky. It's too narrow to act.
The window is effectively slammed shut the moment they leave the womb. And that's what makes the idea of moving the surgery into the fetal period so critical.
Yes. And the authors are really clear about this. We're not starting from square one. The field of fetal surgery is mature now.
Right. This isn't the Wild West of the 1980s.
Not at all. We've seen this progression, from the big open surgeries pioneered by doctors like Harrison to the modern era of hybrid and fetoscopic techniques. things like repairing spina bifida in utero.
A mom-ass
A
trial.
mom-ass trial, exactly. Or treating twin transfusion syndrome. These are now common procedures. That history has built the safety frameworks and the technical expertise we need to even consider something like IUHT.
So the foundation is there. The clinical need is undeniable. Which brings us to the core proposal from Petrakovsky and Nemotin. Use that existing infrastructure to perform the transplant while the fetus is still supported by the mother.
That's the link. That's the whole idea. By doing it in utero, you sidestep the two biggest disasters: the baby's fragility at birth and the body's powerful immune rejection system. You unlock advantages you just can't get after delivery.
Okay, this is where it gets really fascinating. Let's move from the why to the how. The core scientific rationale. Why is the fetus in mid-gestation the perfect patient for a transplant?
The whole scientific argument, the real cornerstone of their proposal, is something called the immune tolerance window.
The immune tolerance window.
This is the game changer. It's what separates IUHT from all those past attempts. A fetus, say between 18 and 30 weeks, has a very immature, very plastic immune system.
And what does that plasticity mean? What's happening inside the fetus during that specific time?
It all comes down to the thymus. That's the little organ that trains your T cells, the soldiers of your immune system, to tell the difference between you and not you.
Self versus non-self.
Exactly. During this window, the thymus is actively learning. If it sees a cell that it thinks is part of the body, it tells the T cells, hey, this is friendly, leave it alone.
So if you introduce foreign cells, donor cells from the new heart during that training period,
You can trick the system. The developing immune system sees those donor antigens and basically says, oh, okay, these must be self too. It learns to tolerate them.
so it accepts the new heart not as a foreign invader that needs to be attacked, but as an original part of the body?
Yes, it's the holy grail of transplant medicine, achieving donor-specific tolerance. And the implication of doing this in utero is it's profound.
Right.
It could potentially eliminate the need for lifelong immunosuppression drugs.
Okay, let's pause on that because that is huge. The side effects of those drugs, especially for a child, are just brutal.
They're devastating. Postnatal transplant recipients, even tiny babies, are on these aggressive drug cocktails for life. You're looking at severe kidney damage, a constant high risk of infection, stunted growth, and a much higher risk of cancer later in life.
So by avoiding that, IUHT isn't just saving a life, it's offering a chance at a normal, healthy life.
A vastly improved quality of life. And we know this isn't just a theory. The authors build their case on decades of related research, right?
Right. This comes from work on In Utero Hematopoietic Cell Transplantation, or IUHCT.
Exactly. We've known for a long time from those studies that you can successfully create what's called microchimerism, where a small number of donor cells live peacefully inside the recipient. That biological foundation is already proven. IUHT is just applying that principle to a solid organ.
So the biology is on your side because of tolerance, but you still have to do the surgery, which is a major stress. This brings up their second big scientific advantage. The fetus is more stable physiologically.
The key is the placenta. The placenta is, for all intents and purposes, the most perfect life support system imaginable.
Yeah.
And it stays online during the entire operation.
So instead of relying on an external machine.
Right. When you operate on a newborn, you have them on cardiopulmonary bypass or ECMO. That introduces all kinds of risks, clots, fluid balance problems, big hemodynamic swings. But the fetus, still connected to the placenta, gets perfect, stable oxygenation and circulation. The placenta handles everything. It guarantees stable blood pressure and buffers any metabolic stress from the surgery.
It's a natural safety net.
A powerful one. It creates a controlled surgical environment with safety margins you could never replicate externally. And that stability is everything when you're trying to perform super delicate surgery against a ticking clock, the warm ischemia time.
And the authors also note that the fetus itself is just tougher in some ways.
It is. Fetal tissues are more resilient to brief periods of ischemia, a lack of blood flow, than neonatal tissues are. And from a simple logistical standpoint, it's actually easier to find a size-matched heart for a fetus within that prenatal window. It removes one more huge variable.
Okay, so the combination of that immune opportunity and the physiological stability makes a really compelling case for why this should be done in utero. But now we have to talk about the biggest historical hurdle: technical feasibility. Has the technology finally caught up to the biology?
And that's the core of their argument. They are meticulous in laying out why the answer is yes. They look back at the high-profile failures of the past, the early attempts in the 60s, the baby fake case in the 80s, and they argue those failed, not because the idea was wrong, but because the tools just weren't there yet.
The infrastructure was missing, the legal, ethical, and especially the technological infrastructure.
Completely.
So let's walk through the specific advancements that they say have closed that gap. Let's start with just getting to the fetus. Historically, that meant a massive, risky incision in the uterus.
Right, a big open hysterotomy. Which brings us to advancement number 1, minimally invasive access.
This is the shift to a hybrid open fetoscopic approach. What does that look like?
It's transformative because it's all about reducing the risk to the mother. Instead of a large cut, most of the work is done through tiny 2 or 3 millimeter ports. You use a camera, a fetoscope, to see and manipulate things.
So you're minimizing the trauma to the uterus.
Dramatically. The actual incision to do the work, the microhysterotomy, is kept incredibly small, ideally under 1.5 centimeters. That drastically lowers the risk of preterm labor and future uterine rupture. We know this works. The success of other complex fetoscopic surgeries proves we have the precision to operate safely in that space.
Okay, so access is safer for the mother, but once you're in, you still need to put the fetus on life support to replace the heart. You mentioned the lack of a fetal-sized bypass machine was a huge historical barrier.
Which brings us to advancement number 2, miniaturized perfusion systems. This is probably the single biggest engineering leap. The work in neonatal cardiac surgery has finally given us true microoxygenators.
What does that mean? How small are we talking?
We're talking about systems designed for incredibly low flow rates, less than a liter per minute total. But the most critical part, the non-negotiable part, is the priming volume, the amount of fluid needed to fill the machine's tubes.
And why is that so important?
Because a 30-week fetus is tiny. It might only have 80 or 100 milliliters of blood in its entire body. If you hook it up to a machine that needs a liter of fluid to prime, you'd cause catastrophic hemodilution. The blood would be too thin to function.
So the system itself has to have almost no volume.
Exactly. The authors specify the priming loop must be 40 milliliters or less. 40. The fact that we now have systems that can meet that spec is what makes this entire procedure technically possible in a way it never was for, say, baby Faye.
That level of miniaturization is a complete game changer. Okay, so you have access, you have bypass, but you still have the clock. You have to connect the new heart, and you have to do it fast.
That's advancement number 3. Rapid anastomosis techniques. The authors are emphatic about this. The warm ischemia window, the time the donor heart is without blood flow, has to be less than 10 minutes.
10 minutes to connect all the major vessels in a heart the size of a grape.
It's an incredible technical challenge. It demands what's called supermicrosurgery. You're using sutures 11A0, 12-0 that are thinner than human hair. But they also point to new tech that speeds things up even more, like tiny vascular couplers that snap vessels together, or even laser-assisted fusion.
So the combination of better imaging, the tiny bypass machine, and these new tools makes that 10-minute deadline achievable.
Predictably achievable, which it never was before.
And we have proof that a fetus can tolerate this kind of complex, lengthy procedure.
We do. Just look at something like the exit procedure, where an infant is partially delivered while still on placental support to work on their airway. That proves the fetus can handle major surgery, while the placenta provides that stable oxygenation. And again, the MAMAS-2 trial for Sina bifida proved the long-term safety of complex uterine surgery. IUHT is an extension of that, not a complete departure.
The technical case is strong, but we have to pivot to what might be the biggest hurdle of all, the ethical one. The controversies of the 80s, especially around getting donor organs, nearly sank the whole field of infant transplantation.
And the authors know they have to confront that history directly. The public outcry over cases like baby Teresa and baby Faye, it all came from a total vacuum of ethical governance. The criteria for determining death were unclear, organ laws were inconsistent, there was no trust.
Let's talk about the biggest storm, which was the debate over using anencephalic infants as donors. These are infants born without the main parts of the brain, but with a functioning brainstem.
Which meant they didn't meet the traditional definition of brain dead, even though they had no consciousness or hope of survival. It was an agonizing ethical problem. How do you define death in a way that allows for organ retrieval without violating fundamental principles?
The historical problem was a lack of a clear, consistent framework.
Exactly. It wasn't a lack of compassion, it was a lack of rules.
So how has modern governance fixed that? What's different today that gives IUHT a clear ethical path forward?
The landscape is completely different now. It's defined by standardization and oversight. First, the determination of death is standardized. It's guided by the Uniform Determination of Death Act, and it's applied consistently.
And crucially, the people making that determination are separate from the transplant team.
That's the second huge change. The
Hmm.
creation of independent organ procuring organizations, or OPOs, they manage the entire process. The team that declares death is completely separate from the team that performs the transplant. That separation is vital for public trust.
The protocols are now clear and transparent. And the authors also say that IUHT isn't solely dependent on anencephalic donors, right?
Absolutely not. While that history is important, modern donor pathways have expanded. The most common pathways now are for donation after circulatory death, or DCD. This is where parents, after a tragic prognosis, elect to withdraw life support and donate their infant's organs. It's all guided by structured protocols and clear, informed parental consent.
Okay, so the supply side has been ethically resolved. Now let's look at the recipient side. The authors actually argue that IUHT is ethically preferable to those historical attempts at neonatal transplant. Why?
The core moral advantage is that you avoid neonatal suffering. As we said, these lethal defects lead to a terrible, agonizing period of collapse right after birth. IUHT happens before any of that. The intervention is planned, elective, and happens while the fetus is stable on placental support. It's an act of beneficence of doing good by preventing that suffering.
But there's still one more patient here. The mother. She's undergoing a major procedure for the benefit of her fetus. This brings up the principle of maternal primacy.
Which is the absolute fundamental determinant of whether any fetal surgery is ethical. The safety of the mother comes first, period. If the risk to her is too high, the procedure cannot happen, no matter how great the potential benefit to the fetus.
So how do they ensure that?
They insist on adhering to the established frameworks, specifically from the North American Fetal Therapy Network, or NAFT-NET.
And what do the NAFT-NET standards demand?
They demand total transparency in disclosing risks, very strict criteria for who is even eligible, and constant monitoring. The risks to the mother preterm labor, hemorrhage, infection have to be managed down to a level that's comparable to other major fetal surgeries.
And modern techniques help with that.
They do. Specialized drugs to prevent contractions, the minimally invasive fetoscopic access we talked about, better ways to close the uterus. It all means the risk profile for the mother, while still serious, is considered manageable and not prohibitive within these ethical boundaries.
So when you put it all together, the Petrikowski and Neymotin framework seems to have systematically addressed every major historical roadblock, the science, the tech, the ethics. It feels less like a concept and more like an action plan.
That's exactly what it is.
Yeah.
And that brings us to their proposed roadmap, the translational framework, how they propose to take this from the lab to the clinic responsibly.
They understand that getting this right means being incredibly rigorous and phased. So let's start with their phase 0. This is before they ever get near a living patient. It's all engineering and ex vivo validation.
Right. They're testing the tools first. They have to hit specific engineering milestones. First, prove the miniaturized fetal bypass circuit works in the lab. Can it maintain the flow rates they need? And can it do it with that critical priming volume of 40 milliliters or less?
They have to prove it on the bench first.
Then second, they validate the rapid anastomosis workflow. They use mock-ups of tiny vessels, and the surgical team has to prove again and again that they can connect everything securely inside that 8 to 10 minute warm ischemia deadline.
It's like a time trial for the surgeons.
It is. And the third step in phase 0 is full-scale simulation, using high-fidelity mannequins to rehearse the entire complex choreography, from port placement to handling emergencies. The whole team has to be flawless before they move on.
Okay, once the tools and the team are validated, then they move to phase I animal models. And the gold standard here is the fetal lamb. Why a lamb?
The fetal sheep is the standard for this kind of research because its heart size, its placental circulation, and its general physiology are remarkably similar to a human fetus at that stage. It's the best model we have for testing the mechanics of the procedure.
And the success criteria are really strict.
Incredibly strict. They have to show the lamb is stable on bypass, the transplant is successful, and that the lamb survives with a functioning heart for at least 24 to 72 hours while still in the uterus.
But they don't stop with lambs. They also mandate a primate validation phase.
Right, because primates are much closer to humans immunologically and anatomically. This is the final de-risking step to really understand how the mother's body will tolerate the long anesthesia and the surgery itself.
Then we get to phase 2, which is so clever. It tackles the rejection problem head-on before the main surgery ever happens. This is the tolerance first phase.
This is where they solidify that immunological foundation. Phase 2 would involve injecting donor hematopoietic stem cells into the human fetus well in advance of the transplant, maybe around 18 to 24 weeks.
And the goal is not to transplant the heart yet, but
Just to induce tolerance, to achieve that stable microchimerism we talked about. They need to prove that they can get the recipient's immune system to accept donor cells safely, without complications, in a significant number of patients.
So if you can prove that tolerance induction works first, it makes the actual heart transplant down the road much, much safer.
It's like an immunologic guarantee. If you know the body is already primed to accept the donor tissue, the biggest long-term risk rejection is already mitigated.
Okay, so after all that prep, the engineering, the animal models, the human tolerance trials, we finally get to phase 3, the first in-human IUHT protocol. The criteria for these first patients must be incredibly strict.
Extremely constrained. It's limited only to fetuses with those lethal heart defects where death is a certainty. The gestational age is tightly controlled, probably 28 to 32 weeks, to balance fetal size with time for recovery. And of course, the mother must be a perfect candidate, meeting all the NAFNET criteria.
And the surgery itself is governed by a very specific plan.
Highly prescriptive. It uses the hybrid fetoscopic approach, the microhysterotomy, the 10-minute ischemia limit, and the whole thing is overseen by an independent data and safety monitoring board.
A DSMB. That's crucial for preventing the kind of ethical chaos we saw in the past.
Absolutely. The DSMB has the power to stop the trial immediately if there are any safety concerns for the mother or if the outcomes for the fetus are not meeting predefined benchmarks. And all the data has to be reported to the NAFTNet registry for transparency.
Let's pull back for a second and look at the projected benefits. After all of this immense risk and work, what's the payoff they're hoping for?
They lay it out in 3 tiers. Tier 1 is the most immediate and, for these families, the most profound. It's simply the conversion of a non-viable fetus to a live birth.
Taking a situation with zero hope and turning it into a live baby?
Exactly. Even if the long-term prognosis is uncertain, that shift from a guaranteed death to a live birth is psychologically and emotionally massive for families.
Okay, what's tier 2?
Tier 2 is improved immediate neonatal quality of life. Because the surgery happens in utero, the baby is born stable. They avoid that terrible period of hypoxia and circulatory collapse. This means the parents can actually hold and bond with and care for their newborn. That experience is invaluable.
And then there's tier 3. This is the home run, the ultimate goal.
Tier 3 is the potential for long-term survival. This is where the tolerance-first approach really pays off. The ultimate goal is a child born with a functioning heart that their body accepts as its own, who can grow up without needing that lifetime of toxic immunosuppression drugs. That would be a paradigm shift in transplantation.
So, after going through this entire detailed framework, the conclusion from Petrakovsky and Neymotin is pretty clear. They believe IUHT is scientifically grounded, technically possible, and ethically sound under modern rules.
Right. Their whole argument is that the modern medical toolkit, the understanding of immune tolerance, the placental support, the miniaturized tech, has finally caught up with the ambition. The barriers of the 1980s have been systematically dismantled.
So they don't see this as an impossible dream. They see it as a solvable engineering problem.
A solvable translational problem. But, and this is a huge but, it's entirely dependent on following that rigorous phased roadmap. You don't skip steps. You prove safety and efficacy at every single stage.
So this is really a call for responsible innovation, not to just start doing this tomorrow, but to start the rigorous translational research today.
That is the critical takeaway. It's the logical next frontier because the science and the technology have finally aligned. The task now is to prove we can execute it safely.
And that really brings us to our final provocative thought. The debate over IUHT isn't just about whether we can do the surgery. It's a test of modern medical ethics itself. Can we, by following a roadmap this rigorous, achieve a level of certainty and governance that justifies this kind of high-risk intervention for the highest possible reward?
The reward being a long, healthy life, free from the burden of immunosuppression, achieved before a baby even takes its first breath.
It's the ultimate expression of medical optimism, but one grounded in decades of hard science, a question that will absolutely define the next chapter of transplant medicine.